He's a urologist in KZN, who's an expert in HoLEP laser enucleation of the prostate. He'll just be sharing some tips and tricks and some experience with these cases. Thanks a lot for joining us, Amit.
Hi, everyone. Firstly, I have to apologize. I'm recovering from a bit of a sore throat, so please excuse my husky voice. Yeah, let's see if we cover this topic well. I'm hoping that you could see my screen.
Yes, we can. Thank you.
Great. Okay. So this is just a little introduction because the HoLEP guys around the world are very passionate about HoLEP. This chap has written a small poem about HoLEP. Yeah, so today we're going to talk about HoLEP and where it fits and what we should be aiming at. We're going to cover a few tips and tricks as well, and hopefully we'll go away with some important points. So first disclaimer, I'm a proctor for Boston Scientific. Right, so when we first speak about lasers, we always think about Star Wars. That's how I always remembered it when I qualified, was that it was still unknown, still something that the first world were investigating and not us in South Africa had available to us. But as time goes on, we knew that TURP was not the best possible treatment. And we know that cutting through the gland was a problem. There was always a problem of increased bleeding, longer irrigation, longer catheter stay, which in turn resulted in longer hospital stay and the gland not completely removed. And I'm sure any urologist that's worth their salt knows that they would have to take a patient back. A fair number of patients go back for an evacuation of a clot, be it in the immediate phase or after 2 to 3 weeks. So the complications of transurethral resection are well documented. We know that overall there's a risk of bladder neck contracture, urethral stricture, there's a transfusion risk, there's TUR syndrome, and failure to void. This particular slide shows that there's even a mortality rate associated with a large gland. And we can't take this lightly. There has to be a better option available. So we look at the guidelines, and I think I have to commend the last speaker. He did a great job of discussing the medical management of BPH. But this is the surgical side, and what we can see is that essentially the laser enucleation has made an impact on our guidelines, on the EAU guidelines. And what's important is that it's irrespective of prostate size. So if you're looking at a small prostate between 30 to 80 grams, well, a medium-sized prostate, sorry, between 30 to 80 grams, or a large prostate greater than 80 grams, HoLEP or laser enucleation makes a presence. And also in patients that have anticoagulant therapy that cannot be stopped, laser enucleation is there. The only phase where you would think twice about laser enucleation would be a gland that's less than 30 moles. Now, this is the AUA guidelines, and it's essentially very similar. They haven't clearly identified what's a small, what's an average, what's a large prostate. But here they've been quite clear that HoLEP is there, and it's a size-independent option. What's more is that in patients with a high risk of bleeding, such as anticoagulants, again, HoLEP is the treatment of choice, as well as PVP and thulium. This slide is with permission from Tev Aho from Cambridge, but this essentially shows that when you're looking at a prostate size, from the 30 grams right until actually, you can go up beyond 190, 200 grams. HoLEP is the treatment that covers all prostate sizes above 30 grams. So we always need to consider, why are we doing what we're doing? Is there a better option? So to discuss HoLEP in general, we need to understand what's AEEP, and this stands for anatomical endoscopic enucleation of the prostate. And essentially, we have two options of this type of enucleation. The one is laser, and the second is bipolar. Of the different options, laser is the far easier instrument to perform AEEP, which is enucleation. Thulium is also there, and green light is there as well. Bipolar is somewhat a little more difficult, but it is far cheaper. We use a loop. You can use, there's different types of bipolar, including the Hermann electrode, which can be used. To discuss holmium laser, essentially, holmium laser is the light amplification of the sensitized emission of radiation. And we know that holmium YAG is a solid state pulse laser. Light is emitted at 2,100 nanometers, and it allows for tissue cutting and coagulation. And the depth of penetration, which is very important, is only 0.4 millimeters. This is a diagrammatic representation of what we just said, that the holmium YAG laser allows for depth of penetration of 0.4 millimeters, which is similar to thulium. And this is the reason why it is preferable. So we can easily work in the anatomical plane, the enucleation plane, without penetrating deeper than the capsular plane. And that's also the reason why earlier lasers like diode and Nd:YAG were not favorable, because of the associated scarring and deeper penetration that happened, and sphincter damage that happened. So again, this is describing the coagulation zone, and the coagulation zone is quite minimal. So again, 0.4 millimeters, comparing it to the other laser types. Importantly, when we're looking at lasers, we need to also understand how the laser is absorbed by the tissue and the fluid. And in order to do that, we measure the oxyhemoglobin level. And okay, this slide doesn't project well, but essentially what we know is that holmium YAG laser has a less of a oxyhemoglobin absorption than thulium, and that could explain why we have less scarring and less charring of the prostate bed with holmium YAG versus thulium. And this is just a summary of the history of lasers, which has been around for years, since 1984, and there's been many studies looking at holmium lasers, which we'll quickly touch on. So Peter Gilling is the father of HoLEP. He started with HoLEP in 1994, with the first initial trial between 94 and 98. And currently around the world, there's 350 to 400 centers. And there's been evolution of techniques. There's the initial 3-lobe, 2-lobe technique, which I think is easier to teach when you start. Then there's the en bloc, which is removal of the prostate in one piece. And then there's en bloc no touch technique, which is by avoiding contact with the prostate during the enucleation, allowing the plasma bubble to do the dissection for you. And this is the latest, and this is the favorable technique, which is no touch with early apical release. And that's very important to protect the urethral sphincter during the procedure. And this prevents the transient incontinence that gave HoLEP a bad name back in the initial phase, where we did a 3-lobe or 2-lobe technique. And there's been moving on to a total en bloc. So you can see that there's a transition from the different types of techniques. So we'll be discussing the end block, no touch, and the total end block in a little more detail. So if those who don't, just as a summary of what HoLEP is, HoLEP follows the anatomical plane between the gland and the pseudocapsule. We're dealing mainly with the transitional zone of the prostate. Actually, we're only dealing with the transitional zone of the prostate, which is the underlying reason for BPE. There's minimal bleeding. It's safe with aspirin. Currently, my surgery is performed as a day surgical procedure with patients discharged with a catheter in 95% of cases. And the catheter is normally removed after 2 days as an outpatient. There's an entity of low power HoLEP, which most of my cases are done with the low power HoLEP, which is, I find it's easier to teach and easier to stay in the anatomical plane, and obviously has a reduced cost. It's almost like using a blunt knife for dissection versus using a samurai sword, which can cause more damage. So just to touch on the end block no touch technique by one of my mentors, Cesar Scafone. And essentially, his technique was firstly a limited apical release just at 12 o'clock. Then the left lobe of the prostate was enucleated from the 5 o'clock position, moving down towards the veru. And the intent is to work purely with the left lobe, lifting up the green area in the lower picture, lifting and separating the left lobe purely. Then once you've released the left lobe, then he would do an incision between 10 and 2 o'clock at the level of the bladder neck. And then he'll work on the mid lobe and, sorry, there's a typo, and the right lobe. So it's the mid lobe and the right lobe of the prostate, with the intention being that you're removing it with the attachment to the left lobe being at 12 o'clock still. So it's completely separated with the middle lobe. This technique progressed, and what is now favored is a total end block with early apical release, which is where you would not attempt to work all the way when you're working with the prostate. You're trying to cause the least amount of traction. You want to be as gentle as possible. You also place a lot of emphasis on enucleating or to separate the urethral mucosa as the first step. So if you look at this slide, you could see that picture B and C, that it shows that the incision is made around the adenoma, with dissection through the urethra to reach the capsular plane circumferentially as the first step. And that's very important to prevent any traction of the sphincter. And then circumferentially, enucleation occurs. Hello? Sorry, can you hear me?
Yes, we can. Yes, we can.
All right. Okay. Sorry. Okay. Yeah. So if you look at moving through the pictures, the intent is that we continue with enucleation around the prostate, keeping relatively at the same level throughout, so that there's limited traction on the actual gland. And this aids in maintaining a particular surgical plane so that the fluid stays within that plane, which helps in dissection and helps with the separation of the gland until you reach the bladder neck. And once you reach the bladder neck, then you release the prostate at the bladder neck, and it pops into the bladder. This is not such an easy technique to learn initially. So I would suggest that if anyone wants to learn, the important aspect is the early apical release, and then either a 2-lobe or a 3-lobe technique, with the intent being to start off with the middle lobe to make a 5 and 7 o'clock incision after doing the apical release. And once you get comfortable removing the middle lobe in a retrograde fashion from the veru to the bladder neck, then you can progress to doing the lateral lobes. The lateral lobes are a little more difficult. So, I mean, if you struggle, then you can always convert to a TRP for the lateral lobes. But just to get your feel, it's easier to start with the middle lobe. Then for morcellation, which many urologists that are not comfortable with the enucleation find quite daunting. Morcellation is important that you get a few factors correct, and you have someone around you that knows what to do and what not to do. So the first thing is that hemostasis is very important. And I make a point of going in a few times, ensuring that we reach the best possible hemostasis state with the enucleation technique. And if you're conscious when you're doing the enucleation to possibly catch any possible bleeders, then it does help. The commonest point of bleeding I've noticed is at the bladder neck. So what I tend to do is empty the bladder, and then once the bladder, when we go in again, then you catch the possible bleeders at the bladder neck. I use a laser to do that on coagulation settings, but you're welcome to use a loop to do that as well, just to catch any possible vessels at the bladder neck. You have to have 2 irrigation sets. So I have 4 bags connected to 2 irrigation sets. Obviously, we're using saline for enucleation, and the irrigation, all 4 bags are open. The reason, obviously, is that with morcellation, we are constantly sucking or pulling fluid in through the morcellator, and the last thing we want is the bladder to deflate, and then you're asking for trouble because you're at high risk of morcellating the bladder. It's also important that your team understands what is required, and often you get distracted by focusing on what's in front of you, which is the morcellation. And your team need to be aware if fluid runs out, that they need to be on top of it and be able to change and so on. The third point is a very simple point, is that you want to keep the probe in the middle of the bladder. You want to keep the prostate at 12 o'clock. We use a Stort's a drill cut morcellator, and the blades are 12 o'clock. And the idea is that you want to keep the prostate on the blades, and you want to keep the probe in the middle of the bladder so that there's less chance of being anywhere close to the bladder walls, and the blade should be completely covered by the prostate. There is a movement towards enucleation within the prostate bed, which I've done in several cases where either the prostate just refuses to be morcellated in a normal way, either it's very fibrous, and funny enough, I found that patients on a 5-alpha reductase inhibitor are more likely to have a fibrous prostate, and in those cases, I pull the prostate down into the prostate bed and morcellate there, which helps because it's a smaller space to work in. And the risks of complications are not as great as if you morcellate in the bladder, but that does not always work. It's actually, I find it easier to morcellate in the bladder. Just to touch on what you would do, I don't have a slide on this, what you would do if you do morcellate the bladder. Now, the first thing is that you definitely know when you have. I know it sounds strange when you should know, but what you feel is a particular type of give or resistance when you nick the bladder. In the 10 or so cases where I have unfortunately morcellated the bladder, they have been superficial. I've been able to realize that I have done so. And fortunately, none of them have been of full thickness bladder perforation, and just going in with a bit of coagulation, helped. So that's important that you understand when to stop and when to take a look, and before you continue. Right, so this is just a comparison between HoLEP and open prostatectomy, and there's no doubt that HoLEP is far superior on all aspects: length of stay, catheter time, transfusion rate, and hemoglobin loss. And in my practice, as I said previously, I currently run a day surgical unit, which means that patients would go home the same day under spinal anesthetic is preferable, and they go home the same day with a catheter, and 2 days later we remove the catheter in the rooms, and the success rate is quite high. So of voiding is quite high. I think I've had only 1 or 2 patients that for some reason, normally it's just constipation that prevents them from voiding. This is just a review of the clinical trial evidence, and this is by Maidstone NHS, and essentially comparing HoLEP to TURP is nothing that we don't know. The length of catheter stays less, Qmax is improved because you're enucleating at the right plane, you're not leaving any tissue behind, and post-void residual is minimal. What's important is that HoLEP and transurethral resection, we know that there's, in one study, there was twice as many complications with TURP as versus HoLEP. And this is another study looking at why HoLEP should be regarded as a gold standard for surgical treatment of BPH. And they've noted that it's poised to replace TURP as the standard treatment, and there's an improvement in IPSS, Qmax, and did not require reoperation of the adenoma. And post-operative complications tend to be lower for HoLEP. And patient satisfaction, 94% of patients were willing to undergo the surgery again. I don't know of many patients that would want to undergo a TURP again, or an open prostatectomy for that matter. It's always interesting to compare thulium to HoLEP. And we know that on paper, they are identical. So the effectiveness and all the parameters are very similar. And Thomas Hirman initially said enucleation is enucleation is enucleation. And that's an important message, that it's enucleation is the most important aspect. Whatever you have available and whatever you're comfortable with, you should use. But we know, coming back, that thulium has a higher reaction to oxyhemoglobin, which causes more effect on the tissue. And we know that there's more energy to the capsule, more scarring. There's a debate about more dysuria, and difficult to access the capsular plane when you can't see where the capsular plane is. Chair, I'm not sure how we're doing for time. Would you, can I continue? I think I've got about 10 more slides. Is that okay?
Yes, you can. Thanks a lot.
Thanks. This is, I think when I came down to UCT, we had lots of fun with oranges. This is important to remember, that with HoLEP, you at the right plane, and thulium, you don't know essentially where you are. You assume you're at the right plane, but often you're not. And what we know is that this was analysis that I did about 3 years ago. There were 14 randomized control trials on HoLEP, and there were just a few 5 on thulium, and most of them were from the same center. So HoLEP is the more proven modality. This is just a touch on high power versus low power. You know that There's, well, basically, Teb Aho from Cambridge has proven that it's not really important the power of the laser. The effectiveness is the same. And a similar type of study was performed by Cesar Scafone and Cecilia Gracco from Turin. And it's feasible and effective as the high power approach in the hands of experienced operators. Why is that important? Is because of cost. A high power laser will cost about R1 million, and a low power laser like this is about half the price. This is an interesting slide. I mean, just for the guys that are budding engineers, it's just to understand how it works. You can see that the laser component of this machine is just at the top, the small little box at the top, and you have a cooler below it, and you have two coolers below that cools the cooler. So essentially, this big machine is just a whole bunch of cooling that's involved. And the actual laser that does the work is just that small box at the top. I thought that was quite interesting. What's important about HoLEP is that you could use it for about lasers. Sorry, HoLEP HoLEP laser is that you could use it for HoLEP, and obviously you could use it for stone. So you can use it for more than one indication. Sorry, I'm just going to skip that. So just to touch on the negatives, the cost, the learning curve, the complications. So we know that there have been several studies looking at cost comparison. And what's important is that in this study from Spain, they've noted that the cost was actually cheaper if you consider the hospital stay and the complication rate when you actually buy a HoLEP or buy a machine and you perform HoLEP versus open prostatectomy. And the same study that I quoted previously compared the enucleation volume as a factor of cost in theater time. And they've noted that HoLEP has a higher enucleation volume for the amount of time that is spent versus TURP. And then just to touch on the learning curve, which we shouldn't ignore. This particular study, 24 studies, 5,000 odd patients. And what they've discovered is that without a mentor, you need about 50 cases to be competent. And with a mentor, 25 cases. I found that the guys that have started with thulium are that much more confident, especially with the enucleation, especially with the morcellation side. And I don't think this is absolutely cast in stone in our environment, but that's what the studies have shown. The idea being that you don't want to be left without anywhere to go, like this chap, where you basically stuck and you have nowhere to turn to. We can skip through this. I touched on late sphincter and early sphincter liberation, and those are my partnerships. And this is just important. This is the Kuntz working elements, KUNTZ working elements with the laser fiber that feeds through it. And that working element is meant to advance the fiber as you need it. And this was broken the last time I was in Cape Town. I couldn't advance the fiber, and that was a memorable live case. And the settings that we use are 39.6 watts with 18 hertz and 2.2 joules. That's the low power HoLEP. And that's my journey so far. Yeah, so I think the important aspect is that you can easily do a HoLEP after having had a TURP previously. I haven't found there to be any issues really. And of the 25 prostate cancers that I've diagnosed incidentally, there have been only 2 that has required treatment thus far. So the other 23 or so we've managed with active surveillance, and the PSAs have not gone up. I've done an MRI on all of them, and it showed that there's no significant lesions, involving the prostate or outside of the prostate. So the international guidelines are that we follow active surveillance protocol, and that's what I've done, and they've done well. Okay, so we skip through this. This is quite interesting. If I can just touch on this, this is the medical therapy, and you can see the invasiveness and effectiveness of BPH treatment. And then we have the new modality, which is slowly taking off in SA. Costs are significant though, and we have Resume available now, which offers improvement in Qmax further than medical therapy, with an improvement in IPSS, and there's a 4% retreatment rate at 5 years for Resume, and no incontinence really, and ejaculatory dysfunction is minimal. And all things considered, it's more poised to replace medical therapy. And then you have definitive therapy, which offers the maximum Qmax improvement with the best improvement in IPSS, with the lowest retreatment rate. Incontinence is the lowest, 1 to 3%. Well, it's low at 1 to 3%. However, has significant ejaculatory dysfunction. We can just skip through this. This covers the benefits again of HoLEP. What's interesting as well is prostate artery embolization is lost a place in the management of BPH in the AUA guidelines. It's only meant for large volume centers, and it's still considered experimental due to the complication rates. And this is just a summary slide of treatment options that we have to remember. And HoLEP is there as the most effective with the least number of side effects of those enucleation treatment options. So we're slowly going where we need to be, making HoLEP the center of treatment for BPH, in surgical management of BPH. And just as a take-home message, we have to remember that it's not the strongest of the species that survives, nor the more intelligent, but the one that is the most responsive to change. And that's from Charles Darwin. Chair, I've got a video, but I don't think I have time for the video. So I'm happy to stop there and take any questions.
Right, thanks a lot, Amit, for an excellent overview of HoLEP, and thanks a lot for taking this up. In South Africa, being one of the biggest guys in HoLEP, probably with the highest numbers. I've had a few discussions about HoLEP because I want to be trained in HoLEP at some point, and I've just got two small questions for you. One. There's colleagues who argue that we have bipolar enucleation these days, which can probably take you up to a prostate of 80 grams easily. And some tend to argue that there might be a small sort of window for HoLEP in the sense that once the prostate becomes too big, you're probably better off doing an open P. I take it you've really presented very serious endpoints here with the length of hospital stay, bleeding, and all the other things you mentioned. So that's the one. First question is, how big can you go? Can you do a 250-gram prostate? And the second question I have, I think it's really been addressed in the few years following the use of laser enucleation, is are there still issues with histology? Because you're going to go and do enucleation of the prostate and use a modulator. Is it still easy? Are there issues with staging a patient well in terms of your Gleason scores and which might obviously affect how you manage a patient?
Right. So thank you for this question. So to answer your second question first, I found that it's if you understand how the anatomical pathologist looks at the specimen, they stain the specimen generally overnight, and that's how it's done, private at least. And within a day or two, they would look at the specimen and identify those areas that are significant. I've quizzed them about this. Is it easier to identify a tumor if you have an open prostatectomy specimen? And essentially it makes no difference, because they are looking at minute changes in staining, and they focus their energy on that. To give an example, I've had specimens that have come back showing 1% has a Gleason 7, or sometimes an insignificant Gleason 6. So it doesn't really affect, morcellation doesn't affect the specimen. To answer your first question about the prostate size, it depends on your experience. There have been numerous mentors, experts that have done prostate sizes of 500, 600 grams that haven't had any issues. I've done the biggest size has been a 400-gram prostate. However, I did it in 2 sessions. This was a few years ago. And the reason we divided it into 2 sessions, the patient was on anticoagulant at the time, and he wasn't a candidate for an open prostatectomy. So I did it in 2 sessions. The problem being with a large prostate is that there's no space to work when you go in, and you literally have to do a 2-lobe or 3-lobe technique. But there is no limitation. 250 gram is that's not an issue. And definitely it just depends on your experience level. So that's essentially my take on that.
Yeah, thanks a lot, Amit. I think you probably answered a bit on Dr. Kalpee's question. Is there any further role for simple open prostatectomy? Any limits to HoLEP, giant BPE? I think you've touched a bit on that.
Sorry, just to step in there. The only other indication for doing an open prostatectomy would obviously be if you have a patient with a huge bladder stone that is going to take you time to remove transurethral. If you don't have the right equipment and you have say a 5-centimeter bladder stone, and it's often easier to just remove the bladder stone and the prostate with an open prostatectomy. But if you do have the equipment like a lithotripter, ultrasonic lithotripter for PCNL available to you, then very easily transurethral you could remove that stone and do an enucleation. I've done that a few times.
Thanks a lot. Are there any questions, further questions for Dr. Kalpee on the floor? Okay. So one last question from my side, Dr. Kalpee, before you go. Once you become a robotic surgeon, then specifically if you're doing radical prostate, and if there's a patient that needs a sort of an open retropubic radical prostate, you'd often refer that patient to a colleague. Do you still do simple open prostates? Because I can imagine probably a very long waiting list for HoLEPs. And do you still have time to do them, or just refer them to a colleague?
Sorry, so you're asking if I refer patients for an open prostatectomy, or you're talking about?
Yeah, open prostatectomy, or you just do them? Because I would imagine you probably have a long waiting list of HoLEPs. And, do you still have time to do them, or you just push and sort of like do HoLEPs? If you find a case that probably needs an open simple prostate, is it something that you still do? You still have time to do now that you're probably running a huge HoLEP service in Devon?
No, I don't do open prostatectomies. If there's an indication that it warrants an open prostatectomy, then I probably pass the patient on to a colleague, because I'd like to just focus on HoLEP. And fortunately, there's been very few patients that actually warrant an open prostatectomy in my practice. So, so I wouldn't be doing an open prostatectomy. I've assisted for a few, but I haven't done one as a primary surgeon for quite a while.
Thanks a lot, Dr. Kalpee. Thanks for your time. It's really been an excellent morning. Thank you so much for an excellent talk on HoLEP. And I think it's quite easy to get your details on the internet. If anyone really needs to be in touch with you, for partnership and stuff, I think we really all look up to you. And thanks a lot for taking this high as to the level you've taken it to.
Thank you, guys.
All right, thanks. Okay, we'll close off the session today. We'll see you guys in the next video.